This is the Shahid Shah Show. Straight talk on building, buying, and investing in digital health. No hype, no buzzwords, no speculation. Just what actually works, maybe what doesn't, and most importantly, why. If you're building healthcare technology or buying it, this is where reality shows up. Welcome to the Shahid Shah Show. If you've spent any time in digital health, you already know the story pretty well. Someone stands on a conference stage and declares that AI is going to transform healthcare. The audience nods. A few people take notes on their iPads. A startup raises $30 million. dollars. A pilot program launches inside a health system. Everyone celebrates the pilot. And then, nothing. Often, the pilot never scales. The startup pivots. The healthcare system moves on to the next conference or the next great startup. But somewhere in a hospital, that poor nurse is still using a fax machine doing things like it was 1995. Now, of course, that's not a knock on nurses. It's a knock on an industry, the industry that we live in, that has spent decades confusing the announcement of innovation with actually delivering it. This show exists because that gap between the announcement and the reality is where the real story lives. And it's a story that doesn't get told nearly enough because it's very difficult to make it entertaining. Those of you that have joined us on this show aren't looking just for entertainment. It's fun to talk about news, views, trends, all kinds of interesting things that happen day to day. But really, you need a place where you can talk about the hard stuff that needs to happen in between patient care, clinical technology selection, and the most important part, which is implementation and diffusion of that innovation. Now, diffusion is a fancy word, but all it means is we have all this technology. Did we actually put it into use in the right places? So now you might be thinking, does the world need yet another digital health focused show when there are so many already good healthcare podcasts, videos, etc.? The internet is indeed filled with awesome audio and video content featuring brilliant founders and visionary CEOs, and other shows cover venture capital, policy, or clinical research. Most are thoughtful and very well produced. But most of them talk about the industry really from a comfortable distance. They discuss trends, investments, predictions, and often we in the content creation universe say things to make ourselves look better, sound smarter, without diving deep into the actual problems day-to-day people face when they are taking care of patients or their loved ones or building technology or buying the technology that is being built. The debate of what happens in the future might be nice, but what really most people care about is what am I going to do this afternoon? What do I do in the middle of the week when patients come complaining and I don't have something to give them? That's what they care about most. What they rarely do in most podcasts, content, etc., is talk to the people who have to make the actual decisions on Monday morning. Think about who those people are. That's the hospital CIO who just got a call from an AI vendor promising to revolutionize care delivery yet again. And then this poor CIO has to figure out in the next 48 hours, because his board or a physician down the hall sent that startup to him to make a decision, whether this product is real or just a marketing deck that learned to speak in clinical terms. Of course, these marketing decks and clinical terms now sound much, much better once they've gone through ChatGPT or Claude or any other AI. So it's that much harder to figure out just by reading something whether a company or a person knows what they are talking about. Do they know the difference between an ICD code and a CPT code? So in this world that we're talking about, things are getting harder and harder. Decisions are becoming more and more difficult because the information space is so full of junk and noise that we're not sure where the signal is. You often hear about the startup founder who built something genuinely useful and cannot figure out why hospital procurement is taking 18 months and still going nowhere. That poor startup founder who may have done everything right when building the product doesn't realize that there's actually what we refer to as a buyer consortium. It's a group of buyers at a health system or in a large physician practice or an imaging lab that has been given the task of finding out whether a product works and then see if that product fits in their workflow or not. And that group of buyers, the healthcare startup, doesn't know that they need to create a consensus. It is their job to help the buyer create a consensus between the front desk people, the frontline clinician workers, the nurse, the doctor's office, the surgical residents. So when you look at all of these problems that a startup founder is going to have, the least of the problem is building the product. Even now, it's much easier to understand what the world looks like inside a hospital just by using AI. But at some point, someone has to go convince one, three, five, maybe as up to as many as 15 to 20 people to convince them, coordinate their decision making to help them understand whether they should buy the product or not. So this is where the difficulty lies. The people every day who have to make these decisions are in a quandary. Then you're thinking about the clinical leader who's trying to determine whether the digital tool that the poor startup founder showed them yesterday will actually improve care or whether it will just create a new layer of documentation that clinicians are going to have to route around the moment nobody's watching. The real world happens on sticky notes still. The real world happens with notes and handoffs between people as they move from one shift to another. Now, this is not a knock on technology to say, okay, technology is never going to work. Technology has been working for decades. We've gotten everywhere from paper to real computers, from mainframes to PCs, from PCs to mobile, from mobile to the internet. We've done a lot, but think about it. If you were in 1995 versus 2005 versus 2015 versus 2025 or 2026, how much of the day-to-day life of a clinical leader or a clinician or a frontline worker in any one of our healthcare environments has foundationally, fundamentally changed after all of that technology? Now, when you start talking to people, some will say, yes, it has. They're much younger. Some of our more experienced personnel say, no, not a whole lot has changed. I just have newer tech. It makes my life easier in some ways. It makes my life harder in other ways. So it's about the people. What are they doing on a day-to-day basis with this technology? And that's what this show is about. Now think about the payer executive who has to sit through dozens of vendor demos and is still waiting for someone to answer the simplest possible question. Great tech. Clinicians love it. Patients love it. Who is going to pay for this thing? And how are we going to get it paid for? In the United States, the healthcare industry has no business model to do the right thing. Now, if the industry has no business model to do the right thing, then it's a very, very important question that all of us have to answer, that even if the tech works, which is a big if, even if every user that needs to use it loves it, even if the disintermediated view between a user and a benefitter, which is, for example, somebody might like the software, loves to use it, and gets value out of it, but is it ultimately benefiting the hospital, the health system, the person who has to pay for it? When you look at all of these kinds of things, the people involved, the tech, the who's building it, who's buying it, healthcare is very difficult to sell into because of all of this intermediation. And that intermediation ends up with that last question probably being the most important: who is going to pay for this thing and how? Now, that question is one we're going to constantly return to on this show because it is full of friction. It is full of half-truths. It is full of myths and misconceptions. But it is the question that most digital health conversations avoid because we're in healthcare. We're supposed to do the right thing. Of course, the technology is going to help patients. Of course, the technology will help improve productivity. But if you have all of that, and you can't figure out how to get paid for, it almost just doesn't matter. This question of who is going to pay for this thing is almost always a question that determines whether a good idea becomes a real product or just a really nice slide deck. So let's talk about something really important at the beginning. Healthcare in the United States does not reward innovation simply because it's good. It's going to reward innovation that someone is willing to pay for. It's going to reward innovation that someone can figure out how to bill for. It's going to reward innovation that can be absorbed into an existing clinical workflow without the whole operation grinding to a halt. Now, a lot of you in the industry know me. I am contrarian in some ways, super optimistic in other ways, but I don't want you to take this as cynicism. It's not cynical to say, great idea, who's going to pay for it? That's just how economics works. And if we keep fooling ourselves into thinking that in the United States, healthcare can do the right thing because it's the right thing to do, of course, you're not going to be able to build the right thing, sell the right thing, because we live in an intermediated healthcare system. And that's just a fancy way of saying that the people who buy our services and the people who sell services are not aligned always in the same way that they are outside of healthcare. So let's look at a very, very simple example in healthcare. When iPhones first came out, no one had to convince doctors, run governance groups, etc., to go and buy an iPhone. They often went into the industry, to an Apple store, purchased a phone, came to their hospitals, found it so valuable that within a few years, it became just a standard piece of equipment that was on their hip belt, just like other pieces of equipment that are in their pockets. Now, what did hospitals have to do? They had to react to a piece of technology that was brought in. That is not the way that most things in healthcare are bought. So when you have a hospital that has a whole bunch of physicians that have a whole bunch of iPhones, those guys are going to get attention because physicians, clinicians are some of the most important people in the hospitals, and they have to be accommodated. Now, think about other technologies that are not being brought in by the consumers and then say, how is that purchased? Well, you have to have a much bigger buying group that has to say yes to something. And if that buying group has to say yes to something and a consensus has to be built, like for example, a massive EHR system upgrade or a brand new accounting system or a brand new practice management system. Those things require multiple people to make decisions. And then the procurement office has to get involved. The payment systems people have to get involved. So those are intermediated. Now, for example, another way of thinking about intermediation is you have CMS, Medicare, Medicaid. They pay for many things on behalf of seniors. Now, even if a senior who happens to be a patient in Hospital X loves something, if the intermediated payer does not pay for that thing to the hospital can't just say, oh, yeah, this is a great idea. The seniors are going to love this. Let's do it. This model, which is our fee for services model, is improving and moving very slowly, inching towards value-based care. But until we get value-based care fully implemented, you're going to have this intermediated situation where the buyer of something, the hospital, can't say, I'm just going to implement this because it's great for my consumers, which is in this case the patients, because a major buyer like Medicare has to figure out how to reimburse it. Now, this is not something worth complaining about. Of course, go to dinner at home, talk about it, complain about it, do all you want to do. But when you're at work, you got to deal with this on a day-to-day basis. This is just healthcare economics. These economics are shaped by very complicated webs of incentives, intermediaries, patient mechanisms that exist only in healthcare. It's not like they exist in 100 other industries and you can just copy and paste those other industries. In healthcare, employers, insurance, government programs, health systems, physician groups, every one of them has a different reason to say yes. Oh, and very importantly, a different reason to say no and veto. In most healthcare buying decisions, you need consensus and unanimity almost to say yes. But one person out of that group, whether it's a 3-person, 10-person, 15-person group, can literally veto. So you have a single person veto with a unanimous requirement to say yes. And that's just to say yes to the product. That doesn't even include all the people that have to then implement it and onboard it, et cetera. This means that every idea that we discuss on this show, every technology, every clinical tool, every AI platform, every digital therapeutic will eventually have to answer the same set of questions. Who pays for this? Through what mechanism? Is it a hospital paying out of their operating budget? And if so, what line item does it come from? And what does it replace? Is it a payer covering it as a benefit? And if so, what's the CPT code or value-based arrangement that makes that possible? Is it an employer offering it to the workforce? Is it a patient paying directly out of their pocket? Is it a government program funding it through a grant that maybe runs out in 2 years? You have to answer all of these in order to get your technology solution into the hands of buyers. And if you're the buyer and you love a piece of technology, you got to figure this out too, so you can help build consensus within your own environment. If none of these pathways exist yet, if the reimbursement isn't there or the contracting vehicle is not in place, if nobody has figured out the billing, then we need to talk about how to build that pathway, not just assume it will sort itself out. And that's really important. It's not like just because a pathway doesn't exist, that the pathway cannot be created or the pathway cannot be cleared of hurdles. So this is why I'm saying don't think of this as a cynical response. Don't think of this as just saying, oh, there's no way out. No, once you understand the problem, then there is a way out almost all the times. And you just have to be more innovative. Use AI to innovate on your business model. Use AI to help tell you, I've got this great thing. Here are the users. Here are the buyers. Here are the people that are going to benefit from it. Let's make this happen and figure out a pathway to getting the payments. Now, using AI to help you with innovation is fantastic. Everybody understands that. But people don't realize that payment innovation may be the ultimate innovation. If you can figure out how to get something paid, other things will get worked out. Sometimes a technology is so good that it will force its way in, like the iPhone in the physician's pocket. But in most cases, that's not the case. It's going to take time, and because that's not how healthcare works, is just making things happen because it's the right thing to do. So great technology without a business model is just a very, very expensive hobby. And part of what this show will do is help builders and buyers think through both sides of that equation at the same time. The technology and the economics, the clinical value and the payment structure, the clinical innovation and the path to actually getting it funded, staffed, and sustained over time. And that's last piece, staffed and sustained. A lot of us forget that once a technology makes its way into the environment, it's still got to be used by somebody. And so staffing it and sustaining it requires the builders to understand how the buyers, whether it's in a large hospital or a small physician's practice, will need to manage that over time, not as an afterthought, not in year 3 after the pilot has been built. At the beginning, figure out how to staff and sustain it at the beginning when the design decisions are being made. So if you have a piece of technology that is saying that it's going to revolutionize healthcare, that's silly. You're not going to revolutionize anything. What you're going to do is improve productivity or help with staff retention or increase the number of things that a single staff member can do without hiring a next staff member to take care of the next 10 patients. So now with all of this said, what's this show really going to cover? The Shahid Shah Show is a practical, candid conversation about digital health, AI, EHRs, medical devices, digital therapeutics, and the operational reality of deploying technology inside real healthcare organizations. It's definitely not a show about hype. It's a show about decisions. What should actually hospitals be asking their vendors before they sign a contract? What should startups build if they want to survive contact with a real health system? What technologies actually work in production versus those that really look good in a demo but can't make their way into production in any meaningful way? Where are all the business model problems blocking good ideas from actually reaching patients? And maybe most importantly, what has failed and why? The failures in healthcare, like in any other industry, are the things that sometimes we learn the most from. We've all heard that said over and over again. But in most environments, we don't like talking about the failures because people believe, oh, if we talk too much about the failures, then nobody's going to work on the tech. It's not true. The more you talk about the failures, the more you talk about why something didn't work, the more likely it is that they will trust you when you say something might work. Be contrarian sometimes, be positive other times, and that just increases trust. And in this case, the technology industry, in many sorts and ways, has lost the trust of its most important group, which is the buyers and the users. Why? Because we promise and then we overpromise and then we overpromise. And most of the time, we can't deliver on those promises. However, in this new AI era, some of that might help us change. So let's address something really quickly. Today's AI systems are genuinely impressive. If you want to understand a regulatory concept, learn about a tech strategy or category, draft a digital health strategy, everything available to you will make that instantly possible. And in a lot of industries, AI has effectively replaced the first several hours of a consulting arrangement and engagement. It's a real shift, and really, really being honest about it, it's helped out in many, many places. But here's where healthcare might be different. And in some cases, it will help in healthcare. In many cases, it won't. But let's be honest about it, right? Just say, here are the 9 areas where it's going to help in. Here are the 900 areas it's not going to today. But in 1 month, it'll be in 10 areas it'll help. And then 2 months, it'll be in 15 areas. It's going to help. In healthcare, AI will shift many job roles, responsibilities over a long period of time. Now, the real challenges in healthcare are not just about information. They're about context. They're about incentives. Who has incentives to do what? It's about workflow and, of course, risk and regulation. Human behavior inside hospital organizations and large healthcare organizations are extraordinarily complex, and they have decades of institutional regulatory inertia baked in. So you have to be careful. What we have to understand is when staff have not been trained well because the training budget got cut, it doesn't help you what kind of technology you throw in. It doesn't matter if the technology works great, but the IT team at the hospital is stretched thin because three other implementations are already running late. It doesn't help that you have a great integration-friendly environment, but there are no people available because your vendor integration assumption turned out to be wrong because nobody read the API documentation carefully enough. The physician champion who drove the entire purchase decision might have just left to accept an offer at a competing health system, and now your champion is gone. So this is where all the experience still matters. And that's what 35 years of actually delivering technology in healthcare, like I've done, gives us all. It's not a theory of what should work. It's a fairly detailed map. So many of the episodes are going to talk about that. So the format of the show is going to be very intentional, but is going to be different in different topics because the problems don't often show up in the same shape. So some episodes, like this episode, is going to be just direct commentary. I'm just going to take a topic, and most of the topics will have come from the industry anyway. It'll be because I've just went to a conference, learned about some things, got some questions from folks, and I'll be answering them. But some are going to feature a hospital executive or a CMIO or a procurement leader talking honestly about how they evaluate technology and where vendors tend to lose the deal before they even know they've lost it. We're going to have infrequent interviews with clinicians, founders, engineers, product builders, because you want to hear from others who speak about these same difficulties, not to talk about yet another great trend that might be coming, but what happened last week when we installed something and it broke down? What happened last week when a problem occurred and a nurse found a solution, which is like often the case? So does the clinical evidence actually support the use case? Does the workflow integration make sense in a real clinical environment? There's like hundreds of questions that have to be answered. And we have to make sure that the payment path is covered nicely. Otherwise, we can't get anything done. A quote like the reimbursement will come is not an acceptable answer. Neither is let's just get the technology to work and we'll figure out the business model after we prove clinical value. It's nice in theory, very, very difficult to pull off. So these are phrases that I've heard many, many times. And then I've seen what comes next. Every idea on this show needs to come with a sketch of how it gets funded, staffed, and sustained, because that's what makes an idea actionable rather than merely interesting. So let me give you a sense of the territory we plan to cover. We're going to talk about hospital technology, why it's failing, why it's succeeding. We're going to talk about why hospitals should be demanding certain kinds of software, but not other kinds of software. We're going to explore digital therapeutics, and we're going to talk to startups that constantly are working on the next greatest thing, but we've got to help them figure out how to get into the health systems and help them sell into those health systems by building the right thing in the right way and moving from there. We're going to look at AI agents. We're going to look at economics of remote patient monitoring. We're going to look at why innovation programs inside health systems produce so many pilots and so few production systems. And we're going to look at all of these things in a way that we can talk about the return on investment. So now, what do we want from you? We've got in the show notes, you're going to find a few links where you can provide your own questions. If you've got 100 things that you've been working on and you've got questions about them, send them our way and we're going to answer them. These are staff questions. We love to hear from the C-suite about the big problems at the highest levels, but what we want even more is in the middle, in the trenches, who's doing what with this technology and where are you getting stuck? So just one call to action for you guys. As you listen to this, share it, tell your fellow colleagues, etc. If they have questions, throw them on. We're going to be talking about real questions, real experience, real decisions, and the business models that make all of this happen. And that's what we're going to be focused on for the next, I don't know how many episodes we'll do, but I'm looking forward to it.